Well, Kim, I see it's 8:01 and we're getting more and more people on. I'm going to click record so that we can. Oh, you have to do record, Kim.
I already did.
Awesome. And we want to welcome everyone to our monthly AVN webinar. Right now we have 16 people on, and we know people will come and go, and we're really excited to have you all here. We're getting a lot of information from people who attend to begin to share, and so that we can collaborate, not just during this time of COVID, but also it accentuates the importance of having behavioral health integration in all primary care settings. And we're very fortunate to have Dr. Alan Mease and Dr. Karen Goldberg today. And so we're glad that you're here. And Kim, do you want to, I'll be quiet now, let you go from there in terms of moderating.
Sure. Thank you all for joining us this morning. We know it's early and we appreciate your dedication to these trainings. For those of you who don't know me, I'm Kim Schuler. Today we're going to have Dr. Mease speaking to us, and he has a colleague with him, Dr. Goldberg, on the line as well. We're excited for this presentation. One of the things I just wanted to kind of put an ask out there. AVN is in the process of writing a HRSA grant. This grant is called the Rural Communities Opioid Response and Prevention Grant. And so we are looking for a couple of primary care practices who would be willing and interested in working with us on looking at the need for services in this area and your specific county, community, and we would have the ability to provide some national trainers on this. So it's an exciting opportunity. Please email me, call me, however you can get in touch with me. I don't want to take too much time on that. So I just wanted to put that out there. We also do have a small participation stipend if we were to get the grant. So Dr. Mease, thank you for your patience with me making that request. We're so glad and so excited that you're here and can't wait to hear your presentation.
Okay, well, it's distinctly my honor to be here. I am, as I like to say, as a well-seasoned pediatrician. That's a euphemism for old. I've been dealing with mothers and babies all of my career, and I was trained in the military and worked and lived in China for 13 years. And Arkansas has kindly adopted this global nomad for the last 5+ years, during which most of the time I spent at the health department, learning some public health and working on some initiatives through the WIC clinic to support young parents and families. I'm excited today to talk about there's no health but mental health as a pediatrician, because I'm going to touch on a number of things I'm really passionate about. So if I get wild and crazy, anybody that has ever heard me talk knows I say similar things over and over again, depending on the audience. But what I want to bring to this discussion of integration of behavioral health is the importance of getting the pediatricians and the pediatric community involved. We have so much leverage, more leverage if we can work in that area. And Dr. Karen Goldberg is a colleague of mine at EQ Health. It's a company that does population health management. We have a contract with multiple states. She works with the state of Florida. I work with the state of Arkansas, obviously, and she's a child psychiatrist. And I'm glad she could come. We are working on a white paper together, which to some degree, bits and pieces of my talk will be part of this white paper. So I will go ahead and share my screen if that works now. Is it working? It worked before.
I don't see it right now.
Okay, hold on. See it now?
Yes.
I've changed the title of this talk a million times, so I didn't know what to call it. And basically, I settled on no health without mental health. And I'm going to talk about my definition and perspective on mental health primarily as a pediatrician, but also one who's focused on developmental issues for the last number of years, as well as a little bit of a global perspective with my time in China. Let's see if I can learn to drive this thing. Okay, how do I change the slide? That I didn't try before. Okay, I'm going to cover broadly a number of concepts, but this is going to have to go pretty quickly. And I want to talk a little bit about global mental health, because this is a global problem. This is not just a US problem. Each country has their unique culture and issues because the systems differ, but this is a global problem. And so we would need to look at global mental health. And a lot of the talk is taken from an article from Lancet, which I didn't put the reference on, but I can give to you, which is their Commission on Global Mental Health and Sustainable Development. It's an excellent discussion. I want to touch on the gap in mental health care, those gaps which we presently struggle with here in Arkansas, particularly. And life course is an important developmental perspective. The lack of the existence of significant fragmentation and lack of continuity, the cost, quality, access issues, and telehealth, which has come to the fore now with COVID. And I hope it basically does not go away when COVID, well, I don't think COVID is going away, so I don't think we have to worry about that. But the other concept is convergence in understanding of mental health and some of our problems with diagnosis. One of my favorite topics is toxic stress and adaptability related to stress, because our kids today and our young families today have a level of toxic stress that's probably greater than the history of humanity. And that's before COVID. Now we have COVID on top of this. As a non-psychiatric trained physician, I've always struggled with diagnosis issues, but I think we're coming to some better understanding of a staging approach to classification and treatment from a developmental perspective. And as you know, social determinants are up in the front of the line as far as issues, thanks to COVID, actually, and issues of social justice. And we know that the sociology becomes the biology, and things like structural racism and health inequity are big problems, as have been brought into focus with COVID. Those are some of the bad news aspects, but we're going to talk about relationships and resilience as part of the good news. I'm going to quickly go through these slides. This is taken from some concepts of what are the three biggest stressors in our society before COVID: technology, the economy, and the environment. And you can see human adaptability does improve with time, as you can see by the line here. But what we're seeing is the rate of change in all these issues is becoming exponential. And this is before COVID. This is from Tom Friedman's work, which I'm sure you read some of his books. But I think we're reaching a point where our human adaptability is being exceeded, and certainly COVID has pushed us over the edge. So what used to be good adaptability, I mean, stress is good because as long as it doesn't exceed the capacity for adapting, when it does, basically you have maladaptation and mental issues. This is one of my favorite ACEs illustrations with an addition it's a balance between the positive supporting relationships or positive forces and the negative forces. But you can see how COVID, with all the issues we're dealing with on the left-hand side, is going to have a tendency to tip the balance. We're going to see I think we're going to see a tsunami of mental health issues. And it's probably already starting, but we haven't seen the least of it yet. This is a crazy attempt that I made to bring together some thoughts on the seeming silos we have when we think about developmental problems, behavioral problems, and mental problems. And we are all in our silos and our bureaucracy in an attempt to meet the needs of tends to focus on funding streams that are developmental disabilities and behavioral and mental separate from those. But there's no separation continuum. And these are all neurodevelopmental disorders based on developmental neurobiology. These are all brain issues. And we have to understand all these in the context of the life course, which is illustrated here by,
Excuse me, Dr. Mease. We do have some background noise. I'm not sure if you're not muted, you might want to try. There's some doors opening and closing and some people in the background, but this is some great information, Dr. Mease. I appreciate the way you framed it up.
Well, again, it's important, and pediatricians are developmentally oriented by nature, but we tend to think development stops, by age 18. That is wrong. And, I think most psychologists and psychiatrists would agree with me that there is such a thing as adult and it continues. And the issue with kids is things are changing so rapidly those early years with regard to their developing brain. It's hard to get stability of diagnoses and trying to understand what's going on. So I think it's important. Life course means development. And the bottom line to this is mental health is developmental health. And this, I think, is an important concept. And, we have to understand the roots of some of these issues based on developmental neurobiology. People know about Erickson's stages of development and a number of things. And when we get into definitions here, the question is, what is mental health? And I think we would not get the same answer from many of us, but Menninger uses the definition of maturity as a definition of mental health. And I think that's a good definition. Capacity for love, the absence of stereotypical patterns of problem solving, realistic acceptance of the destiny imposed by our limitations of time and space, appropriate expectation and goals for oneself and capacity for hope. Maturity is a good definition of mental health. And it is the opposite of narcissism, which is maybe relevant today, but it is certainly congruent with other models of mental health. And I think this is a discussion that's worth having, is what do we think mental health is? If we want to have improve the population's mental health, how do we do it? Lancet, in that article and a couple other places, gives other definitions which include the same things, but I think it's the ability to handle the normal stresses of life is an important issue. And that gets to some of our understanding of concepts of stress. But stress can be good stress, tolerable stress, and it becomes toxic when the capacity of the individual to adapt is exceeded. And this happens the organism is developing brain is much more sensitive from conception to the first 3 years and during adolescence, which we'll talk about. Limitations of mental health diagnoses. This is a problem, and I'm not going to go into this in a lot of detail, except that I think we need to understand diagnoses from a developmental perspective. Early signs of problems of mental health occur in infancy. I am convinced of this, having taken care of many mothers and babies. And you can pick up early the potential for mental health disorders later in life by looking at delays in social emotional development, which can be detected in the first year of life. Therefore, we have child-parent psychotherapy or dyadic therapy. Every pediatrician probably needs to be a child-parent psychotherapist, but I don't know that we're going to make that happen anytime soon. This is taken from that article, and I didn't put the reference on here, but it shows that, depending on when you see the developing path mental well-being moving towards actually specific syndrome or diagnosis. It's a good illustration of how we need to pick up early the signs of these issues because the potential for leverage is great. So what determines mental health? This is another challenging area because we know it's really the social structures play a large role. And what we've learned is the sociology becomes the biology. And it's really our emphasis on biology and the biomedical model is a problem because, you know, our advances in genomics and so forth has put an emphasis on looking at the genes. But we now know that it's actually the dance between the genome and environment that is important. And so structural, social, and economic issues have a profound effect, particularly early in life and during adolescence. And differential exposure to adverse life events. This is why certain people have the issues they have in their health, from obesity to hypertension to heart disease, and why there are disparities in the Black population or the Native American population. It's their cumulative exposure to stress has made them susceptible. So the fact that COVID is disproportionately affecting the Black population or the Native American population is not a big shock to anybody. It could have been predicted, and hopefully the fact that that exists gives us a chance to explain some of these things to our political leaders if they're interested in listening. We can't talk about mental health without looking at the domains of demographics, the economy, the neighborhood, environment, and the culture. This is just a picture from that one article which talks about these things, that social determinants across the life course is what's important. And I guess maybe my perspective has changed since I was a young pediatrician because I'm interested in what's going on with my own development at my age. So as we all go through this process, but these are things that traditionally medical people have just, basically written off, but they're very important issues, and they have profound, this is a slide that really illustrates well the fact that the sociology becomes the biology from fetal life to midlife and late life. And it's I like pictures, so it's a very graphic display of the interaction between the biology and the sociology and the different phenotypes where we come up with diagnoses. And again, we've got to look at things from a life course perspective, which is a developmental perspective. And you can't separate developmental issues from behavioral or mental issues. So if you remember anything else from my discussion, it's, mental health is a developmental issue. Again, the strong association with disadvantage and childhood adversity. Most mental disorders emerge in adolescence and young adulthood. And the numbers on this, I'll go through quickly some numbers later, but the emergence of these disorders is not just going up a little bit, it's going up fairly logarithmically, even before COVID. And that's why I say with COVID on top of what we already know is going on, we have a lot of issues that we can expect to be coming. You all, I hope, have seen this diagram. It's the Adverse Childhood Experiences Pyramid, which has really changed a lot of our thinking about what historical trauma and intergenerational adversity does to affect childhood experiences, eventually affect the social, emotional, and cognitive functioning. That's why the first red flag that this person, this baby, is going to have issues that he has with attachment. And so delays in social emotional development, which can be documented in the first year, puts that baby at risk. And so Then you have health risks. You know, we typically think of health behaviors and say, well, people are not healthy because they don't do the right thing. Well, we know that a lot of this is not a matter of choice, and that basically the behaviors are really a consequence, whether it's substance use disorder or other psychiatric diagnoses. And these then lead to disease, disability, and early death. Neurodevelopment and epigenetic influences are going on here. Why do African American women who are doing well economically still have a higher prematurity rate? The answers lie in the epigenetics of what's been going on. It's not just them. It's what happened to their mother and her mother and, you know, generation after generation. And this is one of the big issues we have to grapple with the demonstrations and everything going on. There is biology behind all this. And, you know, our Black African American brothers and sisters have markers on their DNA left over from their history. Now, people will say, oh my God, it means you're going to blame all this on your mother and the grandmother and everything. No, this is not what we're saying. What we're saying is, in order to understand what's really going on and adjust to it, we have to understand this. I am not detracting from personal responsibility here. And, you know, but we're so obsessed with the bootstrap theory that we can pull ourselves up by our own bootstraps. That is true to some degree, but babies aren't born with boots on. And so the baby is at the mercy of his environment. So the origins of mental health disorders are in childhood and adolescence. Poverty, we know, it has profound neurodevelopmental effects. Neurologic changes during these sensitive periods we can study. Half of all mental disorders develop by age 14, although most remain undetected. And that's the other thing. We miss an opportunity that first 3 years of life to detect these things early and during adolescence. Any of y'all who deal with adolescents know they're a difficult bunch for a pediatrician to deal with, I'm sure for a counselor to deal with, or a psychiatrist to deal with. So the trouble with our data is we don't even know what our data is in America. We have retrospective data based on national youth surveys, and we have data reflecting mental health visits in the emergency departments, which are increasing. We do have some prospective longitudinal studies I won't go into, but they are rare, and we need more of this kind of study to see what happens, ideally, from conception through the life course of that individual and what impact our interventions have on that. The study that I just will comment on quickly is the global burden of disease, which is a WHO study. This is data before COVID, and I can tell you it's going to change. Basically the way to look at this is they basically introduced the concept of a daily. I don't know if you've all heard of this or not, but basically it is a disability adjusted life year. In other words, it's years of life lived with disabilities plus years of life lost over time. And I'm not going to go into the data except to refer you to the study, and it's a very interesting study. It's done globally, over 1 million cases, showed that mental and substance use disorders are the 6th leading cause of dailies in the world. This is a global perspective, and I think that's important. My time in China, the issues that the Chinese young families are dealing with, the stressors are culturally different a little bit, but the results are very similar. But they looked at substance use disorders and mental disorders, and they looked at and have some great data that I would encourage you to take a look at. And so the issue is, okay, how do we deal with this, and what are the approaches to dealing with this increase globally? And we know that this is probably an underestimate because it eliminates suicide and some other things unless they're directly attributable to a diagnosis. And it eliminates other disorders, including ADHD and some of the pervasive mental disorders. So the sixth highest leading cause of dailies is an underestimate. Mental and substance use disorder was the focus of this study. And it is the leading cause of disability in the world. And this includes high-income countries and low-income countries. Obviously, there's a transition from the low-income countries where infectious disease and other things are more commonly an issue. But we have increasing disorders before COVID. And we have some good ideas on how we could intervene, but we're still struggling with being reactive and only dealing with the consequences. In the US, the studies that have been done mainly by surveys have shown there's been an increase in disabilities from 2000 to 2010 in kids 2 to 8 years of age by about 20%. That's why I say these numbers are going up. And we're talking about the disorders listed here. I'm not going to read them, but the trouble with kids is the rates of these change with age, but over time are increasing. So we have to, again, take a look at things over time. And this gives just a graph from one of the studies that was published recently to show increasing prevalence of ADHD, autism, et cetera, et cetera, et cetera. It's the National Survey of Health. The issue with kids is we know these things show up at different points of time over the life course, and this gives a rough idea of the types of things you might see for impulse control disorders. We see kids getting thrown out of preschool because of impulse control disorders, and we blame this on parents because they don't discipline their kids. This is hogwash. This is hogwash. The issue with the parents is the parents have their own issues, and it just continues to be duplicated in their kids. So anxiety, substance use, mood disorders, psychotic disorders, you can see the timing of these things. And again, we need to look at this. We need longitudinal studies. If we're going to implement a program for the preventive aspects of child-parent psychotherapy in the first years of life, we need to follow those kids then through at least age 21 and probably beyond, and if we want to get a total impact. I like to turn the ACEs upside down or on the side to show the emphasis on time. We have a lot of mental health issues. We have a high baseline parent stress level, a baseline prevalence that's high. I'm jumping around here. We've got all the other issues that COVID it brings on us. So we're dealing with stressing. This is we used to talk about the economy and stressors on banking system. COVID is a stressor that shows all the weaknesses of our healthcare system with regard to mental health. So I don't want to be negative, but we got a problem coming and we better address it. So why do we have problems with mental health in kids? Barriers to access, delays in initial treatment, poor engagement with mental health services, barriers to primary care even. Some of our rural states, rural counties in Arkansas is the problem. Kids fall through the cracks. There's not much involvement in the patient from the design of the services, and we're not even incorporating the current scientific knowledge into clinical care. Clinical staging, early intervention during developmental period. We know already what we could be doing, and we're not doing it because our system is not capable of doing it. So threats, a little evidence that we can do anything about this. Financial resources remain low. Pharmacologic and other clinical interventions effects cannot really be measured very well because we lack data. And we see multiple transitions that are facing populations today. Pandemics, conflicts, displacement, increasing global income inequality. This is not a global problem. This is, well, it is a global problem, but it's particularly a United States problem. And our growing economic and political uncertainties with the polarizations that we're seeing and the inability of politicians and policymakers to do anything. Rapid urbanization is a big challenge in China. Everybody moving from the countryside, and what you have is left behind kids staying in the small towns with grandma. And then we're seeing the impact of climate change on our environment. Our biomedical emphasis is we've got to break out of the mold of some of these ways of thinking, because we're not going to solve these problems thinking the same way. So we really have some challenges on our hands, not only on a global basis, but an Arkansas basis. My experience in China prepared me for working in rural Arkansas. And the difference is, well, in China, some people are still born in the barn or out at home and don't go to the hospital. So we were working with some NGOs to decrease that, so improving perinatal health. Well, in the United States, in Arkansas, everybody's born in a hospital, most of it, except people who choose otherwise. But what happens in the United States is after the kid is born, the parents send out of the hospital with a stack of papers saying, here's how you take care of your kid. Good luck. We'll see you next time around. So where do they go first? Their PCP, pediatrician, not likely. The first place they visit is the WIC clinic, which is why that's a great point to do something and why we're working on some projects there. So what's the next thing that happens? DCFS is called, because something is going on. And so DCFS is called, the kid may be taken away from the family, put in foster care, not too much effort done to help the family prevent those things, which would be helpful. And then basically you get into school, unsuccessful school, foster care, and the foster care to prison pipeline, because that's where it starts. If you look at our prisons, the percentage of people in prisons that were in foster care is 60 to 70%, depending on where you want to study it. So we've got to look at things from a time perspective. We got to look at applications across the life course. This is a great picture of thinking about this in terms of life course. You know, we look at the different stages of developing mental disorders, like pre-morbid, which is where we could make a big difference. High risk, fully recover, and so forth. This is based on a model of psychosis, but it's applicable, I think, to looking at any kind of mental health disorder. But you got to look at it in terms of brain formation, brain reorganization, and brain maintenance. It's, again, a great way to look at the impact of interventions over time. But most importantly is what you guys are doing, and what I'd like to join you in doing, which is we need to integrate behavioral health into regular care. And this is a big challenge. You know, when I practiced general pediatrics in many different environments, but I always valued, you know, and wanted to have the psychologist in the practice. Found it very difficult to find a way to do that. But I think this is so critical, and why your work is so important. Mental health services need to be offered on site, and there needs to be direct collaboration with PCPs and psychiatrists. There's a number of models which you guys know well, you know, and I want to talk about integrating it into pediatric primary care. I know Dr. Rogers is a strong proponent of this, but most of the pediatricians who I've talked to in Arkansas have struggled with this and finding a way to make this a business case. You know, we need to figure out a way to make the norm a group of pediatricians supported by some counselors, social work, psychologists, and probably at least a psychiatrist or easy access to a child psychiatrist. I would have a practice tomorrow at my age if I could do a practice like that. But the barriers to doing that are profound. I think too, looking at this from a family-centered basis, when we look at families at risk and why we have such a high prevalence of kids being taken out of the home. This is a model where they had a pediatric, obstetric, and adult primary care clinics integrated into one administrative structure. One of the big issues for young mothers is depression, and from depression to actual psychosis. The way we, as pediatricians, we know we can't take care of the baby without taking care of the mother, and we can't take care of the mother without taking care of the family and the community, and to build a model that supports the whole. This is my favorite slide, which basically shows the layers of protection around the fetus and or newborn. And the layers of protection are either layers of protection or they're layers of risk. Whereas the mother has mental health issues, this is going to affect the baby from conception, actually. And the family under distress, if they can't support the mother, and then the community. If we look at our rural communities like the southeast areas of the state and the Delta, we've got big problems here. And we've got to look at the baby in the context of the environment. But we've got to change our thinking to do this. We've got to break down the silos that separate not only developmental, behavioral, and mental. We've got to break down the silos separating adult and child. Pediatrics is part of that issue. And we take a whole section of time, but we need to look at the child in the context of the family. Family mental illness is a big problem, and it contributes to a lot of the issues we see. We need to screen every mother for maternal mood and anxiety disorders. There's many cases you've probably heard of. They always hit the newspaper like mother kills her baby. And so the normal approach to that is, well, that mother's got to lock her up and send her away. Well, she was psychotic. And it's an indication that our system has totally failed that mother and that family. Treatment of parents' mental health problems is the way you're going to take care of the child. And as a pediatrician, I didn't have much opportunity to do that. Your models of collaborative care, of integrating behavioral health, collaborative, co-located management and coordination. I think the biggest challenge is, I think co-location is required. I think we got to not just put somebody in the office though and have them practice like a counselor or a psychiatrist normally would practice. The behavioral health people need to change how they practice, and so do the primary care people. It requires changes on both sides of that. And it's very difficult because the models of practice are so different. There are early efforts to do this. I don't think we have in Arkansas. We've made some attempts, but I don't know if we have a good long-term model in Arkansas. I'd be interested to learn what you guys know. But we've got to address parent skills deficit and family conflict. Parents don't need parenting classes. That sounds pretty radical. Yes, they do. They need parent support. We need to go beyond classes and to provide them some actually parent support and skills to help them take care of their newborn, because likely the way they were raised is the way they're going to raise their child. And unless we have some help in that regard, the project we're doing in Arkansas, some of the local health units, is to assign a parent support mentor who is a community person with training to support young families for at least the first 6 months of life. We're still collecting data on that. Home visiting, in my opinion, home visiting should be required of all babies born in Arkansas. I don't care whether you're well off or not well off. Home visiting should be required. We have home visiting in Arkansas. Yeah, about 10% of the population that needs it, and a very smaller percent of the total birth population. The other issue is that we could do something about is childcare. For goodness sakes, high quality, affordable, available childcare. The fact that we don't have this as an advanced country is unacceptable. It means we don't really care about kids. And the childcare that is available is often, despite our efforts and the state's efforts to improve it, less than it should be. So, future directions. Both primary care and behavioral staff need to have training on how to do this. We need to have universal behavioral health screening, not just developmental screening. I am the Arkansas ambassador for the CDC's Learn the Signs Act Early program. If any of you all are interested in a developmental program, please contact me. And we do, as pediatricians, developmental screening. We measure height, weight, and development. We need to integrate into that behavioral health, and besides developmental health, and evaluation of family stress in a holistic, comprehensive manner. The SWIC tool is a very useful tool out of Massachusetts that evaluates kids from a behavioral, developmental, and a family stress model. It's something that if I was in practice, I would use. It's very similar to the ages and stages, but goes beyond it to a little bit of a more holistic approach to include behavioral issues. One of the common questions I would get as a pediatrician, whether it's in China or anywhere I practiced in the world, is this child's behavior normal? Because kids have changes in their behavior, and a lot of times the pediatrician is guilty and say, well, it's okay, it'll get better. So time will take care of it. And sometimes and then to find out, well, if this behavior is not normal, or what can I do to make it, or how can I as a parent influence it positively? This a whole other topic, which is discipline. We often blame parent and kids' bad behavior on lack of discipline. Well, I don't think that is necessarily true. It's inappropriate discipline that's often the problem. Now, part of our solution has got to involve digital technology. I'm not going to read this to you, it's just to remind me that we can do a lot of the work, and we're doing it, moving in that direction. But all this temporary stuff needs to be made permanent. You can do good telecounseling via video teleconferencing, but it needs to be based on a relationship with the patient. So that's real quickly a quick overview of a bunch of stuff, and I hope, if anything, I've at least stimulated your thinking to ask some questions and do some more work yourselves. This is my email address. I'd be glad to talk to anybody about any of the topics I talked about. My cell phone is here, and I look forward to hearing some questions and having a little dialogue if we have time.
Thank you so much, Dr. Mease. Yes, actually, we do have a question that someone typed into the chat box. Okay. And the question is, why is the incidence of ADHD increasing, and what can we do to reverse this trend? Following up with, we hate to see young children treated with medications. What's the best alternative to medications for treating ADHD?
Well, ADHD is increasing, of course, and so is autism spectrum disorders and some of the other disorders. And the big debate is, well, is it increasing, or are we just diagnosing it more? Well, I think it's definitely increasing. And I think a lot of it has to do with parenting, but not in the typical sense to say this kid's bouncing off the wall in the supermarket, out of control. The first reaction that you might have is, well, that parent is not appropriately disciplining that child. Well, it's more complicated than that. I think it's increasing because we're seeing because of the toxic stress on the young family and the neurobiology of this, the circuits that are involved in brain development, so we're getting a much clearer idea. ADHD is real. It's not just a figment of imagination. Now, The treatment needs to be working closely with the family to help them understand what's going on and respond appropriately and not make it worse. And Dr. Goldberg can talk a lot more than I can about that. But medication is, if there is one thing that works for a treatment of any one single mental health disorder, it's stimulants for ADHD. But the problem with that is people don't know how to do it. And giving the kid a prescription for a stimulant and sending him on his way and saying, good luck, is not the answer. It's got to be a combined approach. Medication can be a useful leverage, but it needs to be done in the right way. And the right way is not easy. It requires repeated visits to evaluate side effects and benefits of the medication at that dose, and then gradually increasing and not jumping from one medicine to another or adding a second medicine or what have you. But it also needs to include counseling. So it's not an either or black or white situation. I don't like to use medications either. I think I'm a therapeutic nihilist, which means, and I don't trust drug companies. So that makes me very skeptical of the overuse of medication and sensitive to that issue. Karen, what would you say?
Okay, so the question of, is ADHD actually increasing, or is our awareness and diagnostic approaches bringing out more of these numbers? I think that the truth is somewhere in the middle there. I think that there are increases, and it's multifactorial. We don't really know why these numbers are increasing. In terms of treatment approaches, I'm a big proponent of comprehensive approach, an integrated approach, just as Dr. Mease says. There are times when I will work with young families and avoid medication by having a good approach with a therapeutic team that's going to work with parents on setting limits or what have you. Now, if you have a child who's so impulsive and so hyperactive that it's more than what you would expect for that age, there are times where no matter what therapeutic intervention you put into place, you're going to need something to slow that brain down a little bit so that they can grasp the concepts. Okay. And that doesn't mean that we start treating children as young as 3 with a stimulant. Sometimes that's the treatment course, but I tend to lean on the alpha-2 agonist. I don't know if you do, Dr. Mease, but I'll use a little bit of clonidine or guanfacine and slow that motor down so that that child can grasp a concept of how to get into better control of themselves. So it's really a dance of working with the family, the school, the team, the therapeutic team, and getting that child on the right road. I am not a big proponent of, I'm going to start you on medicine and I'll see you when you're 40 and you can finally come off medicine. It doesn't work that way. But the studies do say for ADHD, you can therapize that child as much as you want, but without a little bit of medicine to slow the brain down so that they can grab the concept, you're really just, you're holding that child to a standard that they may not be able to meet without that comprehensive approach. But that's my approach on it.
The other aspect of this, Karen, and all, is that kids with ADHD often have other things, mainly learning disorders. And, you've got to look at this. In fact, the comorbidities of ADHD are pretty profound. First thing you got to rule out in a differential diagnosis is trauma. Kids who've been traumatized will act like they've got ADHD. And that takes a little bit of nuanced intervention and understanding. So it is complicated, but I think kids, the other part of that equation is involving the teacher in school. And how do we do that today? I don't think it happens worth a darn most of the time. And so, the teacher has got to deal with this, and medication is not the answer to solve all the problems, but it can be a useful intervention. Then the question is, do we need a Peter Jensen to do it? He's probably the expert ADHD child psychiatrist in the state, And you ought to get him on here to talk about it because he has an interesting perspective. And I learned most of what I know about ADHD from him. So anyway.
And he's a big proponent of this integrated approach,
Right.
which is terrific. I've met with him when he was down here in Florida.
Right.
Dr. Goldberg, have you worked in any integrated clinics with integrated behavioral health, and or have you seen that model or have much experience with it? And what are your thoughts if you have?
Well, I think it's a very important model goal. I think that we fall short of it. Now, I did my training at Emory in Atlanta for adult psychiatry and child psychiatry, and I thought that they worked with other, because it's an academic setting, with other clinics very well. Okay, so we would have a collaborative clinic, this is during my training, with pediatrics or, with infant mother health. And then my interest, of course, was working integrated with the folks who are working with hearing loss, deafness in children. So they tend to be pilots and models and not something that is well integrated, and they're usually grant-based, so they stop after a while. Okay, so I was most recently, before joining EQ, I was an associate professor at University of South Florida in the Department of Psychiatry, and we had similar things where we would have a grant. We worked with an HIV clinic, so we were integrating for young people under the age, I think they were under the age of 24, working on an integrated approach. It was great. Pilot ended, and that everybody goes back to their corners. And that's the issue, is that we get a pilot, we get started, and then it doesn't continue. But that is critical. I think one of the biggest, and Alan and I have spoken about this, one of the biggest criticisms I've heard over the years for psychiatrists is that once a pediatrician sends the child to a psychiatrist, you never hear back. What you doing over there? How's the patient doing? And that's a huge issue, is that we pull them to our silos, and that's not, my profession is as much to blame for that as any other profession with the silos, but we have to get better at connecting and bringing everyone together again. So that's, if that's helpful, I'm not sure, but I don't think it's well done anywhere. Peter Jensen, I know, has worked quite a bit on that, on trying to integrate these models, but we really need to pilot it. We talk a lot, Alan, you and I, about all the different angles our white paper could go in, and there's so many. But I think the core of every single thing that you and I have spoken about, Alan, is we need integrated care, comprehensive approach to care. Right now, I'm overseeing the behavior analysis program in Florida. I also work in Colorado on their pediatric behavioral therapy programs. And with behavior analysis, we oftentimes see that silo. We have the behavior analysts who are saying, I'm going to work on behavior. I'm going to work over here. I'm on behavior. And many of them are not trained in mental health. Okay. So then you have the mental health providers that are like, okay, well, I'm going to work on mental health. And sometimes their approach is conflict. Well, that doesn't seem to help the child or the family. So just, food for thought there. How do we get that integrated approach is going to be key.
We appreciate your perspective. Thank you. Other questions?
Please let me know. I'd be more than happy to continue this dialogue. And when it involves kids, I think we do need to change our models, our mental models a little bit in order to move forward in this. And that's always difficult for professions to change their models. But for the benefit of kids and the goal of improving global mental health and hopefully mental health in the United States of America, which probably needs some improvement as well.
I really appreciate the fact that you've brought in a lot of the stuff that looks somewhat foundational, that once we get into the clinic or taking care of this patient, or some of these folks are administrators, or that we forget the biology. And so we want a quick answer. The answer is give them Ritalin and take the kid out of the home or something. And so the fact that you've shown us the biology, that the issue has the brain, and all the way going back to the baby prenatally, and it's a systems, it's mother, it's family, it's community, and it's going to take a change of the entire system. And even though your answers have been yes, but, and, because there's not one answer. It's going to take everybody. We had 24 people on this call from different perspectives. It's going to take all these different perspectives, and the mental health needs to change, primary care needs to change, pediatrics need to change, our social system, our legal, and but I think these type of conversations are on the way to creating that change, and we want to be part of that. I know, Kim, you'll be sending out the slides and recording. We've had some people ask because some of your diagrams and your slides were extremely well illustrate complex topics here that are relevant. And then how do we go from here? Would there be any final takeaway that someone could take into their day and into their clinic and into their work today? I know I'm putting you on the spot to say that, but Dr. Goldberg or Dr. Mease?
Well, I think the takeaway is we've got to change our mental model a bit and understand the complexities, and understand. Most of you all are dealing with adults, but so you've got to focus on that part of the life course. Takeaway is adults are still developing too. Number one. Number two is how they got to where they are. You need to understand where they've been, and that's the importance of history. I mean, if you could go back and understand the history, we would be better off. The problem with it is that first 3 years of life is inaccessible. Mm-hmm. It's subconscious. It's it's implicit in the developing brain, but its footprints are there, real, and so keep in mind that, and help, and I think we all need to look ways to push the system towards a model that we could develop that wouldn't be grant dependent, but that would be sustainable from a business case, and the business case is the hard part. And that's why I'm interested in some of our dialogues, Patty, mm-hmm. about how we can develop a business case that's sustainable. And we've got to push any influence you might have on the policymakers and the legislators and the people that run our governmental systems, which to move them in the direction. And COVID may be a good, at least everybody, it's got people's attention. It's like the 2x4. It's got people's attention about these issues. So take advantage of that in your circle of influence.
And I think you make a great point about it is policies and legislative, statewide, countywide, and nationally. And also, we're really thankful that we've had good support from our commercial insurance payers and also our public payers. And I know that's where y'all are coming from with EQ Health. But a lot of times the stress happens, the payers are stressed about what can they afford, and they're trying to figure out how to provide services. But oftentimes the services that end up getting provided are what is reimbursed, what is paid for. And so to continue to move from this fee-for-service model to a population health model that looks not only at the whole patient, whether when they're 55 and have diabetes, but the whole patient back to their childhood and looking at the whole family. So it is going to take a population system approach and us working together on those pieces. So,
absolutely. One of the things that encourages me is looking at some other states. I was at a conference and saw Rhode Island had invested some funds in developing a toolkit and really trying to develop the workforce so they could implement this model throughout the state and really start to address all of the areas. But I think it's going to take that. We're going to have to, on a national level, have support. And I love how you addressed, we're going to all disciplines, we're all going to have to change just a little bit and sharpen our skills and change them so that we're all working together to improve the health of the patient. So you guys did an amazing presentation today. Thank you, Dr. Mease. I look forward to talking to you more about these issues and getting more information. Any last parting comments from our group? I know it's 9:01 and we want to end promptly and be respectful of your time. So thank you for spending this past hour with us.
Thank you. And Dr. Mease and Dr. Goldberg, we had a comment from someone. Thank you so much for your time and energy, and greatly appreciate the emphasis on a holistic perspective for care. So just wanted to pass on that thanks comment from the chat.
Thank you all for listening.
Thanks, y'all. You have a great day.